Welcome to this episode of Substantial Matters, Life and Science of Parkinson's. I'm your host, Dan Keller. At the Parkinson's Foundation, we want all people with Parkinson's and their families to get the care and support they need. Better care starts with better research and leads to better lives. In this podcast series, we highlight the fruits of that research, the treatments and techniques that can help you live a better life now, as well as research that can bring a better tomorrow. In this podcast episode, we meet the researcher, a Parkinson's disease researcher and clinician who has received funding support from the Parkinson's Foundation during his career, Dr. William Dauer. We profile him in his own words, highlighting his interests in movement disorders, career development, and contributions to the field. Dr. Dauer works at the University of Texas Southwestern Medical Center and has had a special interest in dystonia. These involuntary muscle contractions can cause painful twisting and problems performing daily tasks. Early in his career, Dr. Dauer trained in neurology at Columbia University, which has been the home to some of the most prominent and accomplished clinicians and researchers in the movement disorders field. I first asked him how that professional environment helped spur his lifelong focus on movement disorders.
I was a resident in the neurology department at Columbia University, and one of the preeminent groups at Columbia was led by Dr. Stanley Fahn, who is probably the preeminent movement disorders doctor in the world. And in addition to him, he had a whole cadre of amazing faculty. And so as I was a resident, I came into contact with many of these people. They were first and foremost just terrific doctors who cared about patients. And that really caught my attention because my background is that my family has a lot of doctors. I always cared about being a physician and very much resonated with them and sort of how they approach patients. And then, of course, the patients themselves, movement disorder patients. Movement disorder is unique in terms of you make the diagnosis by looking. And even now, our diagnoses are clinical. And so this idea of using clinical expertise to make a diagnosis was really captivating to me. It's not a blood test. It's not an MRI test. It's really by a careful classic neurologic examination that you make a diagnosis. And then thirdly, for movement disorders generally, is that they're just fascinating and important diseases, especially Parkinson's is obviously very common. But there was a lot of fantastic science and continues to be fantastic science about the underlying mechanisms at a very root cause molecule level, but also on how the brain circuits, how signals go around the brain. And movement disorders in many ways continues to be at the vanguard as a way to understand how the brain works. So that was really also very attractive. So all of these things, both the science that underlied things, the types of patients that I really enjoyed interacting with, how I was captivated by them, and then also just, again, the people, Stan Fahn and his group, and how outstanding they were and captivating they were and how expert they were. All of that got me really interested in movement disorders. And there was really no close second, honestly. And then, dystonia specifically you asked about, that really captured my attention in the classic way. I had a patient with dystonia, in particular a form of dystonia that is caused by taking a type of medication that blocks dopamine receptors. And so this relatively young guy had a type of dystonia called tardive dystonia. And just really fascinating to me how a drug could change the brain and cause a movement disorder for life, really, or permanently change the brain. So I was really interested in what's called brain plasticity and how dystonia might be a clue to how the brain changes over time, both in good ways, but also obviously in pathologic ways. And that has borne out. And so that's really how I got interested from that one patient. And then to go back to the people, it just turned out that because Stan Fahn's group was so active, they were doing some of the cutting edge research, and I was able to get involved in that and learn about it. And so all those things combined really got me on my way.
Did you get support from the Parkinson's Foundation early on? And if you did, what did it allow you to do?
The Parkinson's Foundation was absolutely pivotal in my entry into research and supporting me early in my career, which is really the vital time that people need support. So I did get support, and I got support in several different ways. First of all, there was a research group at Columbia at the time that was supported by the Parkinson Foundation, then the Parkinson's Disease Foundation. And so I became a member of that group early and received startup support from my lab, from the Parkinson Foundation, as well as support after that for various research projects and initiatives that I wanted to do over the time. There are two aspects of that that are critical. One aspect is that there was a great infrastructure, both human and otherwise, where I could have a lab. And I knew because of the ongoing support of the Parkinson Foundation that there was some level of support that was going to be there. And so that just creates a certain stability and certainty that is really, really valuable. And then critically, they were there when I had those sort of out there ideas. The NIH is a critical funder of research, obviously, but they're really more conservative as a government organization in terms of what they fund. But the Parkinson Foundation, in addition to doing that sort of support, really is able to fund new, different ideas, things that maybe are less proven and more high risk, high reward. And that's critical to any research environment and program. And so they did that for me, and they allowed me to make some types of discoveries that I think I might not have otherwise had the courage or the backing to do. So it was really, really important.
I guess in lay terms, can you describe briefly what some of those discoveries were or what the applications were?
So dystonia is a complicated problem. There's a type of disease where the only problem that patients have is dystonia, which is a form of abnormal involuntary movement that causes the body to twist or turn abnormally. So you can have that on its own, a so-called primary or isolated dystonia, but you also can get dystonia in Parkinson's disease. It can be a very disabling symptom in Parkinson's disease as well. In the dystonia realm, what is key is identifying a group of cells in the brain, in the area of the brain called the striatum, that are really important in why people get dystonia. And increasingly over time, as that's been looked at, they're not only important in this so-called pure form of dystonia, which I talked about, but also seem to be important in abnormal movements that occur in Parkinson's disease. And so we really went from knowing almost nothing about dystonia on a cellular level to having a real specific target for future research and therapeutic targeting in a variety of disorders, Parkinson's, pure dystonia, and other dystonias, which we're working on now. And so that was really great. I mean, the one other thing I would say is at the time when I started was also really exciting in terms of the first gene for Parkinson's disease was identified, the gene that encodes alpha-synuclein. And it was the Parkinson Foundation that allowed me and other colleagues to do some of the first genetic modeling of that disease in mice. And those models continue to be used today, all these many years later. And they allowed us to learn things about synuclein and its role in nerve cells that continue again to be explored. So it was really impactful in a lot of ways.
People often talk about bench to bedside, meaning from the laboratory bench, those discoveries bringing them to the clinic. But since Parkinson's disease is largely a clinical diagnosis, and even following it depends on questionnaires and rating scales and things that look at activities of daily living and motion and other symptoms, is there an aspect you take from the bedside back to the bench in your research?
First of all, I think it's a great question, and the answer is absolutely yes. I did laboratory research certainly before honing in on dystonia, but my work in dystonia and Parkinson's, first of all, really started at the bedside. So there are two levels of that. One is caring for patients with these illnesses and becoming very interested and, quite frankly, frustrated with an inability to do more for these patients, and that driving the desire to go back into the lab and to learn things about these illnesses. So that's one very generic form of bedside to bench, and I think that's very, very important. Second of all, our work in dystonia, whether in Parkinson's or otherwise, is very much informed by clinical characteristics of the disease. So let me give you just a couple of examples. In Parkinson's, most of the focus is on slowness and stiffness and tremor, which are cardinal manifestations of the disease. But it's only by working with patients who are suffering from dystonia or dyskinesias that you begin to realize that these are really important aspects of the disease that can be very disabling. And it's that recognition that sends you into the lab to, even in the context of Parkinson's, to study things like dystonias and dyskinesias. Otherwise, you might just kind of be stuck on the kind of classic descriptions of, tremor and things of that sort. So that's a very clear example of identifying an aspect of a disease that may not be its most well-recognized aspect, but one that is very important to patients and can cause a lot of disability and unhappiness. So that's a way you really can go from bedside to bench. And then second of all, we've used our understanding of a form of dystonia called DYT1 dystonia, which actually emerges in children, and understanding when it happens during their life and look at that and then go back into the lab and look at specific points in time as the brain is maturing and understand why would the dystonia begin at this time rather than another time. And that's provided really important clues to why the disease happens. So to be clear, looking at timing in patients and going back and trying to replicate that timing in the lab. So that's another bedside to bench. So it really is a collaboration between the bench and the bedside rather than an arrow one way or the other. And I think it's really that collaboration and that back and forth and having great people on both ends who are also both interested in the other end that is vital really for the best science and really to change people's lives, that's ultimately what we're trying to do here.
Science itself is not done in a vacuum. It's a human endeavor, and there's competition, there's collegiality. Do you find that the Parkinson's Foundation sort of pulls together or supports the whole ecosystem of research in this area? In part.
It very much does. I have been very impressed with the foundation over a long career of watching them, back when it was the Parkinson's Disease Foundation and now even more so as the Parkinson Foundation. They are clearly looking at the whole spectrum of needs for the research community. They are funding young career researchers, which I think is so important. They are also funding multidisciplinary grants now where they're asking investigators in a grassroots way to identify a problem that they can attack through collaboration. More and more, it's very clear that all of these problems in Parkinson or in neurologic disease generally, they're not going to be solved by the sort of the genius in the attic or the basement. They require groups of people, so-called team science, because there's just so much expertise that's involved and so many different elements to the problem. And so I think funding those sorts of multidisciplinary groups is also really outstanding. And then they convene people. They really form an important aspect, a glue for the community, to be honest with you. The field would not be where it is today without the kind of work they're doing. That's just a fact.
What do you see coming along? What's, either big areas or what excites you in the field now?
Probably the two biggest areas in Parkinson in my career have been both very important. One is the genetic discoveries. When I was a resident, I was taught that Parkinson's disease was not a genetic disease. So, by really smart people. But obviously, we know that's now completely wrong. There's now more than 20 genes implicated in Parkinson's disease, and many of those are very, what we could call strong genes, meaning that they have a big effect. Many are small too. So that's one area. And the other area is so-called neuromodulation. So things like deep brain stimulation or high-intensity focused ultrasound. So modifying circuits to improve symptoms of the disease, even as we try to understand the root cause from the genetics to slow or stop the disease. So just looking forward in the field of genetics, we're learning more and more every day. There are now multiple trials going on based on that genetic understanding. So far, we have not been successful, and it's been frustrating to us all. But I think as I look forward, there's just a lot to learn, and the pieces are coming together. And What I'm looking forward from that is a targeted therapy based on that root cause of the illness to either slow or halt its progression. That would be just so wonderful. I think we're closer to it than we've been, but we have to keep pushing along that road. In the deep brain stimulation area, I think the classic way of doing this is just having electricity going into someone's brain at a particular rate and a particular voltage and so forth. But more and more now, the technology is advancing to where people are starting to develop devices that would listen to parts of the brain to know when there should be a stronger signal and a weaker signal, a so-called closed loop system. So it's really like what we would call brain-machine interface that is responding to what's happening in the brain rather than just going from a pre-programmed menu that gets done in the clinic. And so I think that will be very, very helpful in the future to be able to respond to different brain states. And bottom line is to give patients a better quality of life, which is always the ultimate goal. I think in both of those, in that root cause and as well as that sort of neuromodulation field, there will be better and better things coming. Instead of just directing an electrical pulse, they're detecting what the consequences of that is for the brain, either at the circuit level, or maybe people will be wearing little micro transducers on their limbs so it knows if you're shaking and things like that. And that's very much what people are thinking about. And there's a tremendous merging. I mean, we're aware of biomedical engineering as a truly merged field between biology and engineering. And biomedical engineering and neuroscience are merging closer every day, adapting deep brain stimulation for Parkinson's and for other diseases of the brain, related movement disorders, tremors. They're coming. It's just a matter of when. And there's a lot of really bright young people, and makes the job of the Parkinson Foundation all the more important to just keep amplifying these efforts. I'll just tell you a very quick thing, which is not exactly Parkinson, but it is approved for Parkinson, for people with really intractable tremor, or for essential tremor that's intractable. You don't even need to get an implantable stimulator now. You can get something called high intensity focused ultrasound, where you sit in an MRI machine for an hour and sound waves are delivered to your brain, all focused on one point to make a tiny lesion about the size of a half a grain of rice. And you walk out of that scanner with greatly reduced or no tremor for many years at least. We're still studying that. So this is an incredible revolution. I mean, to think that you could walk into a hospital, not have an incision, not have anesthesia, have a procedure where sound waves are put in your brain and have symptom reduction or elimination. That really is science fiction, but it's not. It's actually what's happening today. It's not for everyone. It's for defined patients at this point. But I mean, it's tangible progress that all of the research that we've been doing is over time paying off. And there's similar lines of research in biomedical engineering and pure engineering and physics and all that. And all these are integrating in new ways to come up with new ideas. And by the way, the pandemic has been, of course, horrible for everyone, especially people with Parkinson's and other chronic diseases. But this connection now that researchers have through Zoom and other things are only accelerating the pace of interaction. And so I think the future is very bright. I don't downplay the challenges by any means, certainly not a Pollyanna, but I am an optimist, and I think the future is bright. It's just a matter of really the government, foundations like the Parkinson Foundations and others to really help spur these efforts, help get the funding that's needed, and help attract the really smartest people to the job.
Good note to end on. Thank you very much. To find out about how the Parkinson's Foundation supports career development of young researchers and what funding support it provides to established researchers, search our website at parkinson.org on career development and on research we fund. You can also click on the Research tab on our homepage, where you'll find a section on information for researchers. For example, one program, the Launch Award, aims to cultivate a strong cohort of new and talented independent investigators dedicated to Parkinson's research. The award supports mentorship in research training and career development, and then independent research. In today's very competitive environment for research funding, This award prepares the best and brightest U.S. and international early-stage investigators to become independent leaders heading up their own research teams. This is only one among very many research awards, grants, and programs that the Parkinson's Foundation sponsors. As Dr. Dauer discussed, he has had a special interest in dystonia throughout his career. To read more about dystonia, search on Dystonia on our website. Among other articles, there's one on strategies and tips for dealing with dystonia, including suggestions from people with Parkinson's and from care partners. Also, by searching our library at parkinson.org/library on dystonia, you can find an article called Dystonia in Parkinson's Disease, as well as links to several past podcasts mentioning the topic. And of course, our helpline information specialist can provide more resources. As always, they are available to answer questions in English or Spanish about today's topic or anything else having to do with Parkinson's. You can reach them at 1-800-4PD-INFO. News and updates about future events and resources are available by joining our email list at the bottom of our website's homepage. If you want to leave feedback on this podcast or any other subject, you can do it at parkinson.org/feedback. If you enjoyed this podcast, be sure to subscribe and rate and review the series on Apple Podcasts or wherever you get your podcasts. At the Parkinson's Foundation, our mission is to help every person diagnosed with Parkinson's live the best possible life today. To that end, we'll be bringing you a new episode in this podcast series every other week. Till next time, for more information and resources, visit parkinson.org or call our toll-free helpline at 1-800-4PD-INFO. That's 1-800-473-4636. Thank you for listening.